We're to the point where putting a cat in a tank of anesthesia gas, we now know is not appropriate. Does it happen some places sometimes? I'm sure it still does. Because no offense to them, right? If that's where they're at, that's where they're at. But we know now we can do better.
Welcome to the Purr Podcast, your favorite feline-focused podcast, where we dive into all things feline. Medicine, surgery, behavior, and of course, a sprinkle of veterinary gossip along the way.
I'm Dr. Jolle Kirpensteijn, feline fanatic, surgery nerd, and self-proclaimed lover of all things awkwardly cat-related.
And I'm Dr. Susan Little, proud cat vet, podcast enthusiast, and your guide to the wonderfully weird world of feline medicine. Let's get started.
Hi, this is Dr. Susan Little.
Hi, this is Dr. Jolle Kirpensteijn.
Now let's see.
See, you did it on purpose.
I did.
Yes.
So just for the benefit of our guest, who we will introduce in a minute.
Yes.
So we've been recording already today, and Jolle started to mimic my intro.
Right.
Yeah.
I did.
Jolle started to
And so
I was going to do it too.
She definitely,
I tried to bring it down.
Yes.
And I tried to do Jolle.
Yes.
Didn't work. I don't have a Dutch accent for one thing.
No, that's true. But it's interesting because it does help you though, because you make less mistakes.
I do?
Yeah. Yeah. I mean, it's just it's.
What's the less mistake?
Okay, so we're 242 podcasts.
Yes.
Away from our start.
Yeah.
And
8
Dr.
years.
Susan still has a little bit of an issue with the intro.
Yeah. Yeah.
So we hope at 250 that she will have it
When we
control.
started yesterday, I remembered the name of the podcast, but I forgot to say my name.
Right. So my name is Dr. Jolle Kirpensteijn, and this is the Purr Podcast.
Yeah. I'm going to go home and practice my Dutch accent so I can sound like Jolle.
Right.
Yeah.
That adds a little.
Right.
I thought so.
Yeah.
So,
gotta work on it.
Yeah. Like Steve Dale always says, I have a, what is he?
What is he? I have a face for radio, he
Yeah.
says.
Yes, I heard him say.
Right? Hey, introduce yourself, special guest,
Yes,
Dr.
special
Tammy.
guest.
Tell us who you are.
I'm Dr. Tamara Grubb.
You're new. You're the first time.
Yeah.
This is my
another-
very first time, so
Yeah. Virgin.
A virgin.
yes, a little nervous because I've been told that if I say something stupid, it's going to be out there.
It will be.
So.
But we say something stupid all the time.
Yes. So
It'll
that's
get
what I
lost.
said.
I'm
See,
in good
see.
company then.
It'll get lost in all our
Yes.
stupidity.
I said the same thing about
Yeah.
Dr. Susan. All right.
Yeah. Okay. So, Dr. Tammy, tell us
Yes.
about yourself.
So I am a board certified veterinary anesthesiologist, which
Ooh.
I love. I can pass gas and it's not inappropriate. You don't have to
Right.
believe that.
Anesthesiologists have the best jokes.
I know
Yes,
they do.
yeah.
They really do.
Yeah,
They do.
maybe it's like all the sniffing I said, it kind of goes to our brain.
4 years.
But the other thing I am, which is really, I think really the most important part about me, is I'm also a certified veterinary pain practitioner through the IBAPM, and pain
Wow.
management is just my absolute passion.
Yeah. So, pain management seems to always go with anesthesia, doesn't it? Not always, but often.
Yeah.
Comes under that umbrella of anesthesia.
Yeah, it really does. And I think it's the whole anesthesia and analgesia, first of all, that's our college. But
True.
anesthesiologists in all species, I guess, human medicine started it probably, but they're the advocates for the pain management in acute pain because that really helps make anesthesia safer. Clients, patients have better recoveries.
Right.
And so they kind of started it. And then veterinary medicine, we picked that up. But there's a lot of other input too. So anybody who likes cats, I'm sure, you do pain management. And then with chronic pain, the sports medicine folks, the physical medicine rehab folks. And
Yeah,
so
that's true.
it's really expanding. But you're right, acute pain is kind of anesthesia.
Starts with the anesthesiologist. Yeah.
We like to
We
think
haven't
so.
had that many anesthesiologists.
No, we've
on.
had Sheila Robertson on
Yes.
a couple of times.
Yes.
But I don't know, maybe one other.
Yeah. So, and then, 250 episodes. We should be ashamed.
Well,
Yes,
there's not a lot of boarded anesthesiologists,
Oh,
I think, compared to, like, there's a lot of internists
True.
How many anesthesiologists
how many?
are there?
It's a good question. I'm embarrassed that I don't know. But I do think we probably are still the smallest college.
Oh, really?
At least among the smaller ones. Maybe some of the newer ones are smaller because they're growing.
Right.
But not everybody wants to be an anesthesiologist. It can be stressful.
Sure.
And so I think people are at that whole life and death moment. And
Sure.
we can be kind of droll, we're gas passers.
Yeah,
We're
sure. You're either built for it or you're not. I think.
So my image of anesthesiologists normally is that you're the coolest people because you don't get stressed as quickly. Or is it internal stress?
Best. You're the best. Yeah, of course, sometimes internal stress, but I like to project that that persona when everything's going crazy, and I'm like, just take a breath. It's okay. Get some morphine. It's fine. For the patient. So I like to pretend like that. So
of course I'm a surgeon, so the only time that I know that an anesthesiologist is stressed when they scream at me that I have to open the chest now.
Yes. And do you listen?
Of course I listen to you always. So it's dying. Open the chest. Okay, there we go.
We just want to save it. So,
exactly.
And sometimes surgeons are so focused on what they're doing, which is good if you're the surgeon, because your ears aren't open. So sometimes
it does take, when you think about veterinary medicine, I think for a long time we've known that surgeons are different people.
In a nice way.
I'm not saying just
not weird. Just
your
different.
brain operates differently, right? Because you do so much more with your hands, like you do a lot. You're all imaging is always involved, so you're just thinking in a different way. If you're an internist, right? Which I'm not a board certified internist, but I do.
I was going to say
mostly
it doesn't.
Right.
It's
all internal medicine, right?
Because
feline medicine is very heavy on internal medicine, right? And I just think a different way.
Yeah.
And I've always thought anesthesiologists as well must, right?
They're
you have to. Well, maybe that's it. Introduce yourself. The difference between an anesthetist and an anesthesiologist.
The words are totally used interchangeably, as we know, but the technical difference is an anesthesiologist is really a specialist, and an anesthetist is just someone.
Anyone off the street.
Right, exactly. Maybe with some training. So an anesthetist is someone that does anesthesia, but it's not necessarily we're certified, but we use it so interchangeably.
Yeah, we do, don't we?
Yeah, and the anesthesia, how I got into it, I just want to share really quick because if you had told me I was going to do this when I was in vet school, what is that in anesthesia? And I came from mixed practice, working in a mixed practice at home. I was a tech, and we weren't really techs back then. And then was in mixed practice when I graduated. And I was really enjoying it, but I thought I want to do more horse medicine. And so I was practicing in Oregon. And the vet school there at that time had what was called a fellowship. And it was like an internship in that it was 1 year, but it was like a residency in that you had to have training because you were running the horse clinic at night doing the colics and stuff. And so I did. It was awesome. But I had to scrub in with surgeons. And no offense to surgeons or equine surgeons, but just standing there with my hands clasped like this was just like, I can't do this. I don't want to do this.
For hours.
Yeah, for hours. And I thought I wanted to be internal medicine, so horses, but it's like they're close to cats.
Yeah, I know.
Every horse barn has a cat. So,
yeah. I think there are similarities, actually.
I think so too. I saw the anesthesiologist there like day and night having to do the cases. And I thought, I'm going to pretend to be really nice and ask if I can do a rotation with him and offer to take his call just because I didn't want to be in surgery anymore. And I did that. And so saying the anesthesiologists think differently suddenly is like, this is my personality. Like things are happening and you're making decisions and you go, okay, I'm going to turn on the ventilator or whatever.
You're in the moment.
In the moment and
person,
you live with it.
Yes.
And I didn't know I was actually quite that much.
There you were.
So I was like, my gosh, this is me. And then your patient stands up, the pain is managed, and you go out.
I just wanted to say, it's a door-to-door service. You're there in the moment, and then, okay, it's your problem. See you later, bye.
Away you go.
What happens? Where is my anesthesiologist when I need that
person? Something to be said for that.
Yeah, exactly.
Because although you have the worst, that's the positive part. The negative part is you have the longest part that you are on the job in emergency at night situations because you have to come in early and you have to wait until everything is done and everything is clear. The surgeons that do the little thing and then they go home and you're still stuck.
Yes, and so very good point. And so like speaking of, you make fun of me for saying but we're trying to get the patient transferred to ICU or wherever they're going to go, and we usually don't just leave. And so I said we intubate and leave. I mean, extubate and leave it wasn't.
Right. So are you from Oregon?
No, I'm from Texas.
Where in Texas?
A little town. I'll say y'all and Dixonton here at some point. But you got to get that in the transcript. A little town called Fort Davis, and it's out sort of close to El Paso, but kind of close to nothing. Yeah. Close to Big Bend National Park, also sort of. So El Paso is our commercial airport when I fly home, and it's 3 hours. So that's how.
Oh, wow.
So did you grow up like with animals at all, or?
Yeah, it's ranch country, so lots of horses and cattle. And I always had a pony. Right. Or then graduated to a horse, and we had dogs and cats and gerbils, and yes.
And did you go to Texas A&M?
I did. Where did you go?
Well, I'm Canadian, so I went to University of Guelph in Ontario.
So nice. I'll be there.
Yeah.
And you went to vet school, I guess, somewhere where they speak with your accent?
They do.
I went to Utrecht University, which, by the way, is the first accredited vet school outside of the United States. Wow. 1974.
That is cool.
Right. Yeah. And so, and then I did my internship in the University of Georgia, and my surgery residency and master's degree at Kansas State, and then my oncology fellowship at Colorado State.
Wow, he's been around a bit. He's done a lot.
I know. He has done a lot. Yeah. You'd never know looking at him.
Right. That's exactly it. Right, and I dealt with a lot of anesthesiologists. And I have to say, some of my best friends were anesthesiologists.
So we are all fabulous. Look at the group of friends you have.
Exactly. So I don't think we can function as surgeons without anesthesia.
Well, I think not.
I would hope you don't try.
Yeah.
Although I think a lot of the people that are listening to the podcast, they probably don't have a dedicated anesthesiologist. Right. So they have to do everything.
Absolutely, and probably we all came from that in our early, we understand that. And because I was in private first opinion practice before I went back to academia, like I said, and I so appreciate all of that. And it's one reason I was a little bit behind today is because there were so many questions at the end of my session, and I don't want any veterinarian or veterinary technician to leave without getting their anesthesia or pain management question answered. Sure. And it's amazing how we absolutely do well. I think anesthetists in academia or even private practice, referral, surgery centers, that's different, because they're often different cases. But the cases that we're doing in private practice, a technician who's really trained in anesthesia, has learned how to do anesthesia. I don't mean they have to be a specialist, but they do a great job.
I have two techs who have been with me more than 20 years. Right. So they're from the era when not everybody even got their RVT. Like they went to tech school, but they didn't even necessarily pass an exam. And they me and the other vets and stuff, we'll ask them, like, we'll go to them and say, let's talk. And what do you think? And they're prime in that discussion because they're so good.
They are so good, and they notice things that we go, I should have noticed that. I should have thought of that. I should have, what about his renal disease, doc? I'm like, thank you. I forgot.
And it's interesting because at the university where I used to work, we, of course, had students doing anesthesia. We had technicians doing a great job. And then we have one anesthesiologist that kind of runs around multiple hours. But I can imagine that it's stressful when you are in private practice as a veterinarian and you have a technician because you have still the responsibility, the end responsibility.
Yeah, for sure.
You need to do two things at the same time, which it's more stressful, I think.
It's very stressful, and anesthesia is scary to more veterinarians, at least ones that have talked to me, more veterinarians than not scary.
And so I get it.
Cats, especially in cats, because they don't tell you anything until they're done. So they're secrets.
Yeah,
the secret lives.
Yeah, cats are tough.
The ones are worse. Guinea pigs.
Really?
Guinea pig anesthesia. I mean, they tend to die. I mean, suddenly they're dead. So
I think
like
a lot of
crazy.
exotics, are there exotics?
Yeah.
Kind of weird.
They are.
And
there's so much that we don't know. There's not a lot of pharmacokinetic studies.
Yeah.
And a lot of the tiny ones are harder to keep warm. And we know hypothermia is a big detriment to them. And
I have to tell you, I've actually spayed 2 rats, pet rats.
Wow.
That's my claim to fame.
That is, you are famous.
I know. So, because I had to figure out the anesthesiology. I mean, like, what do you give a rat? So it turns out they're really good with ketamine. So I, had to figure out how to anesthetize them. And then spaying rats is completely different than any other animal. So
that's interesting.
I know they were my daughters, and they kept breeding. Like one day, one day she had 2, and the next morning there was 10. I'm like, okay.
That's how it happens. So going back to the guinea pig, what is for a healthy guinea pig? What's your favorite protocol?
For all of those, I really like ketamine and an alpha-2, so dexmedetomidine usually.
Right.
Alpha-2s, they're underestimated drugs. They are great sedatives, got some analgesia, and they're reversible. And that's really a great safety net. So what did you use for yours?
I didn't. I did have my anesthesiologist do it, and I'm like, okay, don't talk to me about the guinea pig. I just give me the time that I have. Right.
Wow, you've been well trained by your anesthesiologist.
Yeah. They kind of like me. So
where are you working now?
Oh, like a lot of us, everywhere. I'm officially retired from academia because I was like, that was fun for a long time, and then was an adjunct professor, and I thought I could retire. Yeah. So still consulting in some veterinary schools and still hand in places. Yeah. Working a little bit in our private practice. Now my husband's just first opinion practice.
Oh, okay.
It's really fun and keeps me honest.
And
it's where I get to see chronic pain patients.
Keeps you grounded.
It does.
Yes.
And that really never worked out in academia because I really wanted to start a pain clinic and was told, sure you can. After all your anesthesia duties are done, I'm like at midnight to 2. So now in his practice, I can see real chronic.
And that's a shame. And it does say something about the attitude.
Yeah.
That is still a bit too pervasive.
I agree.
Right.
It's just, and I'm sure there's other areas too, which is I have to know how to manage, but just thinking that it's just not important and people won't pay for it, which really shouldn't. I mean, but there's just not a need for it. And just,
there is so much need for it.
I would love to talk about pain in our second episode if possible.
Oh, are we coming to the end of this episode?
No, we're halfway.
Oh, okay.
Especially for cats. I think there's a lot of questions from our audience about anesthesia and cats. And obviously the anesthesia depends on how sick the patient is.
Yep.
I guess. So, but, and so in your regular practice, how much cats did you do?
Like now or when I
in
first
general,
like in your husband's practice, is it?
It's growing. But I was still less than the other species, so maybe 30%. But probably back in the day it was maybe 10. And it's not that there weren't the cats out there, but our cat. You can't. I don't know. This is how I feel about my cats. You can't say cat owner. No one owns a cat. So cat parents, caregivers, whatever you want to call them. They didn't know to bring their cats in, or they were barn cats and nobody.
Especially rural areas.
Right.
So it's growing because of that, because of the education of the pet caregivers, and I think more human-animal bond, and then just our knowledge too, and learning how cats are different.
I think you're right, especially with anesthesia, because you can correct me if I'm wrong, but with a lot of things in feline medicine, it's always started by, well, here's what we do in dogs, or here's how liver disease is in dogs, right? And then we'll kind of move from there. That's just been the way, hasn't it?
Yeah, absolutely.
And I feel like anesthesia's been like that.
Yeah.
But, fortunately, especially the last 10, 15 years, right, we can finesse much better.
Yes.
We use, or we should be able to use a wider array of drugs, right?
Right. And we're to the point where putting a cat in a tank of anesthesia gas, we now know is not appropriate. Does it happen some places sometimes? I'm sure it still does. Because, no offense to them, right? If that's where they're at, that's where they're at. But we know now we can do better, and we're getting people to do better, and there's so much, so much wrong with that, and it's sort of like back in the day when so many of us did that. I did too. You don't know what you don't know. Exactly. We didn't know.
It's so bad for yourself. I mean, I remember
Yep.
You know, when you open the thing, it's like,
Yeah.
whoa.
But again, you don't know what you don't know, right?
No, and who was at that point thinking of the health of all of us, and especially our techs that are doing that over and over, that it's not good to be exposed to anesthetic gas over and over and over. Am I worried if you have to go have a surgery and have anesthesia a few times in your life? I'm always worried. I'm an anesthetist, but I think you'll be okay. But daily, multiple times daily.
Well, they use propofol. I know it's so wonderful. It's the wonder drug. Have these minor procedures, and they come with the white stuff. You're like, oh, and 10, 9, 8, you're gone, and then you wake up and
you pop right up, and what happened? There's not that hangover feeling. Very, very different. I think our cats and dogs feel that way too.
I feel like anesthesia is one of those areas where trying to decrease a cat's distress and anxiety and fear has to be, and increasingly I see people who are talking about anesthesia talking about that, right? And that's new-ish.
It really
is newish, isn't it?
It is newish to the point that some people are still really recalcitrant about it and saying, well, you're over-medicating cats. No, we're medicating appropriately. The cat. Like it may seem over to you, but this is what the cat needs. So it's not over to the cat. You're absolutely right, isn't it? It's almost miraculous that we've learned this with cats, that they made
such a difference.
It has. And the using the anxiolytics ahead of time, and all the gentle handling, and the
so talk me through
minutes.
it a little bit from you know, the day before. From a veterinarian's perspective. So when do you start fasting them? You know, when do you use the different drugs in time?
Yeah, the fasting has changed a little bit too. You know, we used to be these really long fasts and nothing to eat after midnight, and of course nobody's been up at midnight feeding them, and so it was, you know, maybe nothing to eat after 6 p.m. and then no water, and that was kind of the first change. Like, no, they have to have water. They're getting dehydrated.
The no water thing never made sense.
No, me either. You're not probably the water's going to be absorbed.
And how much water does a cat drink anyway? I mean, it's not a Labrador. It's going to take on a gallon and walk away, right?
Even then,
the Labrador can absorb the gallon, and then the kind of starting to see too from studies that, and based on what's happening in human medicine too, or what it has happened, is that these really long fasts can actually be detrimental. That changes the GIPH, changes motility, causes anxiety.
Yes, exactly.
Especially just think of some of the other species, some of those high anxiety other species, and not give them food. Oh my goodness. Cats are probably like, excuse me, I was going to say a bad word. They're calling us a bad word as a cat. Like jerks. How's that? Cats are jerks. So now a lot of the guidelines are really probably 6 hours is plenty to empty the stomach.
Because a normal gastric emptying time is fairly quick in cats, right? Because they're small, frequent meal eaters, right? So they're moving food through.
Right, they're catching the next mouse.
Right. If you think of it, right? They don't eat big meals, which an omnivore like the canine species are more attuned to eating a bigger meal, right? And cats are like a mouse at a time, so their physiology moves. It moves it through fast. We usually, if it's elective, we usually tell owners just whenever you go to bed, just pick up the food, leave the water down, right? Or if under some circumstances, we'll just say when you get up in the morning, take away the food and leave the water down. I think we're moving to the point where fasting is becoming, I don't want to say obsolete, but it's becoming very minimal.
Right.
Isn't it?
Yeah, I think so too. And if you think about anesthesia cases that come in as emergencies, we've all anesthetized a patient.
No, I know.
I say that.
That's very funny that you said it, because I love the fact that the radiologist tells me, there's food in the stomach, you can't anesthetize that. I'm like,
hello?
How do we do that when it's an emergency?
Right, exactly. We have to do it. Absolutely.
Or your team going, the owner forgot to fast this cat, it's being spayed. I'm like, well, if it was dying and it needed surgery, we'd take it. So, and I think, I just think we overthought, didn't we?
I think so too. And maybe we just weren't as good at managing it too, because now we know, and especially like you said, with the faster onset induction drugs too, like give a little bit of propofol, be immediately ready to intubate it and inflate the cup. Yeah, that's what, if we treat the airway every time like it is an emergency, then it was the same, right? So, and we should be doing that anyway. Getting them intubated.
So fasting 6 hours or less, and then? So do you start with the good
Pre-meds?
Love to start, as we've already said, with the anxiolytics the day before, the morning of. The day before is nicer.
What do you pick? What's your favorite these days?
Gabapentin is still my favorite. And yours?
So gabapentin, but is not the pregabalin licensed?
Pregabalin is licensed.
Have you played with it yet at all?
Yeah. And I do agree that it is more... It is more effective.
It's a little more rapid onset, maybe?
More rapid onset.
It's supposed to be.
Yep. And a little more effective for both anxiolysis and then also analgesia, which that drug is not licensed for,
but still.
But pregabalin in human medicine is FDA approved for a lot more pain syndromes, chronic pain syndromes, than gabapentin. And the reason is because it binds better to that presynaptic calcium channels that it blocks. And so it's a better binding.
Right.
So, yeah.
So really, I wonder if we're going to eventually see like a swing away from gabapentin.
I would love to see that. Yeah. And I said gabapentin now just because it's the more ubiquitous one. It's like used a lot. But yes, pregabalin. And this shouldn't be a hurdle, so I'm going to say it out loud. The only... not a hurdle, but a consideration of pregabalin is it's a class 5 drug. It's a class 5. Like it's not really, that's at the bottom. But that does in some states not limit, but cause a lot more paperwork. For us, we have to record it for sure. And we have to tell the owner this is what it is, but we don't have forms to fill out.
Yes.
So it shouldn't be a hurdle, though. We should find a way where the forms are
if it's better suited to the task, then you just have to take it on.
Yeah.
So hopefully it will eventually become available in Canada, licensed for cats.
Oh, you don't have it?
No. It's often drugs are licensed in the US first.
Okay.
It's rare that it's the other way around. Yeah. But
what's the trade name?
Boncat.
And
who's the company?
Zoetis.
Yeah. So, so hopefully we will eventually see it in Canada, and I'm definitely game to give it a try.
It is, you'll like it. It's just smoother, it's nicer, it's more predictable. And again, it's that binding. It really is a better drug. It's not just because it's licensed for cats.
Right. However, having said that, I am a big proponent, if there is a licensed drug for cats, especially, please use it. We can't complain that we don't have enough drugs.
Right. And that's why we should make it a non-hurdle to use this approved drug. Because, just thinking it's medicine, but also economics. If you're a drug company and you make a drug and nobody uses it, it's cats, you're not going to make another cat drug. Maybe. I don't know.
That's exactly the point.
Yeah.
You like using other meds that the owner might to give at home or on arrival. Like I'm thinking of Serenia. Do you feel that that's should become part of like even most elective procedures? Because I know some anesthesiologists are moving to that spot. What do you think about that?
I love that. I also, like we've been talking about too, there's in private practice, first opinion practice, and you have clients with all economic levels. So it's adding, I understand both sides of the discussion because it's adding in another expense. And so at what point for spay or neuter are we getting too expensive? On the other hand, we've underestimated how our pets feel, our patients feel when they vomit. We've always gone, they always vomit. Well, it's still not pleasant. We've just ignored it because we didn't have a lot to do with it. And so I do think the vomiting is distressing. And for instance, right now, one of our dogs, she's a nude rescue dog. She gets car sickness. And so when we first got her, we could not get her. We couldn't figure out what's going on. And we finally were lifting her up and then she's vomiting and we're like, this is probably it. We can fix this. And sure enough, now we medicate her before every car ride. And so now she sees she's not going to vomit. And she'll just draw the jump now and she wouldn't get in. And seeing that impact on the pet, it's stressful enough to come to the hospital, get a car, and especially the cat. And so why not take all of that stress away? Because that, as we started with stress, why not take it away? And then also there's vomiting and aspiration. And
there is. Yeah, and I think the other hugely unaddressed part is how nauseous a cat, probably also the lesser species, can be without vomiting.
Yes,
if you've ever had general anesthesia yourself, which I have had, and I know everybody's different, but I woke up not in pain, but so nauseous.
Yeah. And that just feels so bad. And just, especially if you've had abdominal surgery, and you're nauseous, and you're splinting
and
your
you've got ileus. So I think of cats getting spayed or any abdominal surgery,
I think so too.
We don't
removal
think about that.
and
Opening the belly is way more traumatic.
Yeah. And if you have nausea on top of that.
And to see those little kitties just sitting there just drooling, and what makes me maybe a lot crazy, and again, no offense to the surgeon, but what often is the question from the surgeon to the anesthetist is, shouldn't we give some atropine? We should give some analgesia.
Are you serious?
I'm dead serious. Not most of them, no. So it's all surgeons listening out
but
there.
Still, you will still get that.
But it has not been unusual to hear. Yeah. Okay. Treating the symptom, not the problem.
So for our podcast guests, I'm a little open mouth at this moment.
No more atropine.
Wow.
At least for them.
Right. Well, it's just fixing the drooling, but it's not what's causing the drooling.
Right. So going back, so you give the drugs to the owner then to take home to give. How do you know that they do it?
Oh, well, you don't.
Yeah, you don't. Yeah, I agree. Yeah, answer right there.
Mm-hmm.
No, you don't. You just have to trust and hope, and and we do ask them, and if they didn't, we'll give it in the hospital. So we hope they're honest with us, and we all know pilling cats is difficult.
But that's what we'll do, right? If we know it on admission, we'll just give them the drugs right away, because often it'll be a few hours anyway before they.
Right. You've got a little bit of time.
You have a bit of time to play with.
The Bobcat has made that a little bit easier too, because since it's a liquid. So the owners, they're more likely to get it. Because no one, pilling a cat.
Right.
Yeah.
No transdermal painkillers,
Is there one particular?
Have something in mind?
No, I'm just asking. That seems to be the trend.
Oh, yes.
Oh, well, I guess for localized. So you're thinking, is that what you're thinking? Like localized pain?
Just a generalized
pain. Well, in a cat, you can rub anything on its ear and it's absorbed. So just rub it on its ear.
Yeah. Anything.
Whatever.
Anything.
Whatever.
And for a healthy cat, what's your favorite protocol?
So for a healthy cat, definitely start same story. I love the anxiolysis in cats. It makes everything better. And so get them in with anxiolysis, some Cerenia. And then I'm an alpha 2 girl. So, sedation with an opioid and alpha 2. So usually dexmedetomidine. And then induction, I love propofol because you can titrate it to effect. But ketamine and a benzodiazepine is also very good.
There's so many different ways.
Alfaxone, I think that's nice.
I think
we finally have some choices.
We have a choice. And you know what, the old saying is the safest drugs are the ones you're familiar with, right? And so I don't think people should feel bad if they're not like on the newest drug, as long as it's appropriate. Right. So I just quickly have to tell you that I went on a trip to the Galapagos with a nonprofit veterinary group who provides like spay and neuter services, because there's no pet vets on the Galapagos Islands. Canines and cats are not even supposed to be there, but they are. Anyway, so this nonprofit group, and you have to bring everything in with you, and so we can't do anything inhalant. You have to do everything by injection. 9 times out of 10, we had no running water, no electricity, right? And that really brings you back to basics. And so we did a lot of ketamine and acepromazine.
Yeah.
Right? Like you use appropriately what you have to use.
Right. Yeah.
Right. And we had I don't think we had any opioids. Local blocks. Yes. See, like you can do it. So, my point is just there's many ways to do it, right? And you don't have to, if it's not within your like ability, or depending on where you live, you may not have access or knowledge of everything, that you could do. There's still a lot you can do.
Well, I agree.
This has been great.
Yeah.
Yeah, we're at time. So
Jolle's sitting there thinking, stop talking.
We'll come back. She will keep on talking for the rest of her life. But we will be back with pain management.
You can leave. We're good.
In 2 weeks. So I'm very excited about it.
Okay.
I'm not even paying attention.
He's not.
So it's just like a surgeon just doing their
job.
Surgeon.
This is the Purr Podcast, where we talk cats, laugh a lot, and learn something new every episode. Together, we bring you the latest updates, surprising cases, expert interviews, and just a touch of chaos, because nothing with cats ever goes as planned.
So whether you're a seasoned veterinary pro, a new grad, or you're just here for the cat puns, you've come to the right place.